I'm Thomas Baldrick here at the ASH 2014 conference in San Francisco. We're excited to have with us Jacqueline Barrientos, MD, from the North Shore Long Island Jewish Cancer Center. And you're excited to be here at this
Ah, yes,
conference.
absolutely. We
Why?
have a lot of new agents now in the pipeline that we're seeing the light and are now available for our patients. So there's many new targeted drugs that are showing efficacy in the new phase 3 data that we're going to update at this year's ASH. So there's a lot of excitement from all of us to hear about how these new drugs work and what we're seeing on the long-term follow-up.
Let's talk about your phase 3 Resonate study. Why did you decide to undertake this study?
So for us, we had seen very exciting data on the phase 1 and the phase 2 that was very promising, particularly in patients with 17p deletion, which is the chromosomal aberration that kind of like tells you that the disease is going to be more aggressive. Traditionally, patients with a 17p deletion usually die within 2 or 3 years, and we had a need for those patients. So when we saw the activity of the study and the drug in phase 1 and phase 2, we incorporated patients that had the 17p deletion and also any patient with any prior relapsed refractory disease. They were randomized to receive Ibrutinib or Ofatumumab, which is an approved drug for patients with fludarabine refractoriness or ball kill disease, and compare them as a monotherapy. One is an infusion and Ibrutinib is an oral drug. Follow them up prospectively to see what drug is better, and Ibrutinib showed clear superiority in overall response rate and in improvement in progression-free survival and in overall survival. And that's what we are seeing now. But this was the trial that led to the approval of the drug in the United States for relapsed refractory patients, and also based on the data for patients with 17p. The drug is the only drug approved for 17p deletion patients, even in patients that have never received any prior chemotherapy or any therapy.
Let's talk about your study methods and the results that you found.
Yes, so we essentially studied also the well-being of the patients, because it's not only important to have the patients respond to a drug, it's the quality of life that you have. And what we found is that these patients not only are responding, they also have an improved quality of life that is statistically significant by measures that we follow, the FACIT score for fatigue. It measures how well you're doing on a day-to-day basis. And essentially, the study that I did measured that to see how people are feeling, and they felt clearly much better when they took the drug, and very quickly. The other thing that we started to study on our, on this particular trial was to see how people respond in terms of low counts. Our patients have anemia, thrombocytopenia, and low neutrophils. And essentially, this trial is showing that when you're on the drug, all your numbers go up. Your anemia improves, your low platelets improve, and your neutropenia improves. We also studied the role of immunoglobulins, because our patients with CLL have low immunoglobulins for the most part, and there was a concern that maybe the drug may affect the quality or the production of the immunoglobulins, and this was not seen. Essentially, it doesn't affect the immunoglobulin production, and on the contrary, what we are seeing is that over time, people have less infections while they are on this drug. So we're thinking that the reason for that is because the T cells get more potent, and we also found that there's an increase in the percentage of cells, of T cells. So we're very happy with that. So it not only makes you feel better, you also have a response, you are in remission, and your immune system gets better. So those are all the things that we are presenting at this year's ASH.
I can sense your excitement for this.
Yes.
So what do you think is the clinical impact or significance?
So for the first time, we're seeing a drug that is not chemotherapy, that can put you in remission, that can make you feel alive and as energetic as you were before you had the diagnosis of a cancer. And this, I'm seeing it in my clinic. This is something that it's palpable. Patients are very happy. They don't feel like they have cancer anymore, even though the cancer is still there. Like, lo and behold, you stop the drug, the cancer is going to come back. But at least they don't feel that they have to think, oh my God, how many more months do I have to live? Now they have kind of like a very optimistic view of the world, that they are going to die of something else and not of the cancer itself, which is amazing for a drug that is not chemotherapy. We were only able to achieve these things usually with chemotherapy, and it comes with their side effects: nausea, vomiting, infections, blood transfusions. We are not seeing that with this drug, and that is all drugs have their own side effect profile that we have to be aware of. In particular, for example, with Ibrutinib, we are concerned about bleeding risk, but the bleeding risks are essentially possible as long as you know the side effect profile. You just minimize the risk by telling the patient to probably stop the drug a couple of days before any surgical interventions. So as long as you know the side effect profile, you can kind of like preventively tell your patients what to expect. And it's a very exciting thing for me to see my patients coming back and hugging me, just saying thank you for doing this, because I have now patients on this drug. We participated in the phase 1, phase 2, so I have patients on this drug for 3 years now, and they are still in remission. So it's amazing, an amazing time.
It's a powerful story. Thanks for
Yes,
sharing it, and we hope you take this enthusiasm into even bigger and better things.
Yes, of course. We always are trying to think if we can avoid the emergence of resistance, for example. Over the years, in a couple of patients, people stop responding. Not the majority are still in remission, but we want to understand who are these people that stop responding, how can we make it better so that they can stay in remission longer. So maybe in the future we may consider some sort of combination, which is what we're going to do in prospective trials now, thinking of targeting different pathways. This is kind of like the drug that opened Pandora's box. You hit a target, the sky's the limit. Now you have proof of concept that if you can rationally design a drug that just targets the mechanism that is driving the cancer, then maybe you can generate other drugs that target different pathways and then combine it and then see if you get a better outcome.
Thank you, Doctor. Come back and visit with us again and give us updates, would you?
Okay, great. Of course.
Excellent.
Yeah, thank you.